All right, future nurses, let's just dive right in. I know that pharmacology exam is breathing down your neck, so we're going to do a high-speed, no-fluff review of the stuff you absolutely, positively have to know. This is your rapid-fire review.
I get it. The pressure is real. You've got exams, clinicals, life. It's a lot. But just for the next few minutes, let's you and I push all that noise away and get totally laser focused. Because, look, pharmacology isn't about memorizing every single drug on the planet. It's about safety. It's about knowing those critical things that keep your patient from harm. And guess what? That's what's on the exam. So let's start with the big ones, the drugs that can make a patient bleed. Okay, first up, these high-alert medications that mess with blood. There's a reason these are such a huge focus. The risk for bleeding is off the charts. That makes them priority number one for you to know inside, outside, and backwards.
So let's break this down, because this is a classic exam question. You've got two main types here. Think of antiplatelets, like your aspirin, as traffic cops for your blood cells. They tell the platelets, hey, don't clump together. Anticoagulants, like warfarin and heparin, work differently. They actually interfere with the proteins that create clots. So, two different roads leading to the same destination, preventing clots.
Okay, so picture it. Exam question. You're discharging a patient on warfarin. What are the absolute, non-negotiable warning signs you need to teach them? This is more than a test question, you know? This is a life-saving conversation you're going to have. And here they are. These are the red flags. You have to teach them to look for stool that's black and tarry, vomit that looks like coffee grounds, that's digested blood, any weird bruising, especially those little pinpoint dots under the skin called petechiae. Heck, even blood coming from their ears or showing up in their tears is a major call me now signal.
So what's the simple, super testable advice you give them? It's this easy. Use an electric razor because you're way less likely to get nicks and cuts. And be super careful about falls because even a small bump could cause a major internal bleed. These are the easy points you just can't afford to miss.
All right, let's switch gears to our next high alert category, central nervous system depressants. Yep, we're talking about opioids and benzodiazepines, two drug classes that pack a serious punch and come with some life-threatening risks. Okay, pop quiz. You're about to give morphine. You check all the vitals, but which one? Which one is the absolute number one priority? The one that screams danger if it's wrong?
It's respirations, always, every single time. Opioids can cause what we call respiratory depression, which is a fancy way of saying they can slow down or even stop a person's breathing. This is the single deadliest risk you are monitoring for.
But you're not just a breathing counter, right? Your assessment goes deeper. You're checking their level of consciousness. Are they too sleepy? You're watching their blood pressure because it can drop. And of course, you're checking to see if the medicine actually helped their pain. And please don't forget to ask about their bowels. Constipation with opioids is practically a guarantee.
And what if things do go south? If those respirations tank and your patient is unresponsive, you have to know the antidote. That is naloxone. You'll hear it called Narcan all the time. Burn that name into your brain. Now for opioids' cousin, benzodiazepines. If there is just one single piece of patient education that you have to get right, it is this. You tell them you cannot just stop taking these pills. Stopping a benzo suddenly can cause severe, dangerous withdrawal.
Before you even give a benzo, you have to be a detective. Your assessment is everything. Does this person have a history of addiction? You have to ask. Are they having any suicidal thoughts? You have to screen for that. Do they have something like sleep apnea? Because this med could make it worse. Are they already a fall risk? You have to think about all of this.
And just like with opioids, you gotta know the antidote for a benzo overdose. It's flumazenil. Seriously, these reversal agents are free points on an exam. Opioids get naloxone, benzos get flumazenil. Got it? Okay, deep breath. Let's pivot from those high-stakes crisis meds to the everyday workhorses, the meds for chronic conditions that you are going to see all the time, like ACE inhibitors and statins. Here's a question I would almost bet money will pop up on your test. A patient on lisinopril calls the clinic. They're complaining about a new symptom, and it just won't go away. What is it? It is that classic, annoying, dry, hacking cough. And what's really important here is that you need to teach your patient that this is a known side effect of the medicine. It's not that they've caught some new bug. That little piece of education can save a ton of anxiety. Now, let's talk statins. 3 teaching points you have to know. 1, no grapefruit juice. It sounds weird, but the interaction is real and it's important. 2,
They must report any new unexplained muscle pain right away. It can be a sign of a really serious complication. And 3, you've got to remind them that the pill helps, but it doesn't replace a healthy diet and exercise.
Okay, time for a lightning round. 2 more absolutely critical safety rules. They're simple, they're direct, and they could definitely show up on your exam. You ready?
This isn't a suggestion, this is a law in nursing. You never, ever, under any circumstances, push potassium directly into an IV line. You just don't. It can stop the heart. It must always be diluted in an IV bag and infused slowly. No exceptions. Period.
And this one is all about simple logic. If a patient has 2 inhalers, a bronchodilator and a steroid, the bronchodilator, like albuterol, always comes first. Why? Because you have to open up the airways so the steroid medication can actually get down deep into the lungs where it needs to work. It's like opening the door before you try to walk into a room. You know, we've covered a lot of specific drugs and rules, but it all comes back to a fundamental way of thinking. It's a core nursing mindset that applies to every single medication you will ever give in your career. It really boils down to these 3 things. 1, assess your patient before you give the drug. Check the vitals, check the lab work, know their history. 2, educate your patient. They need to be on your team, they need to be your partner in safety. And 3, monitor for a response. Did the drug do what it was supposed to do? Are there any side effects? This is the cycle of safe practice.
So, when you walk into that exam, and more importantly, when you walk into your patient's room, don't just think about drug names. Think about the person. After all this, what's the one safety check, the one piece of education you'll remember that could protect your patient tomorrow? Because that's what really matters. You've got this. You can do this.